Good afternoon and welcome to our Learn and Share conference call. I'm Russ Derry, Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for today is medication side effects, and we're pleased to have as our speaker Dr. Maysaa Basha, who is an epileptologist with the Comprehensive Epilepsy Center at DMC Harper University Hospital and Wayne State University. So welcome, Dr. Basha, and can you briefly introduce yourself, talk a little bit about your clinical and research interests, and describe your experience with this topic?
Good afternoon, and thank you to Russ Derry and the Epilepsy Foundation of Michigan for choosing a very important topic, I think, for us to talk about this afternoon. As Russ mentioned, I am an epileptologist, a seizure doctor, and my practice is at the Detroit Medical Center, where I see 99% of my patients in the clinic are patients with epilepsy. The main component of managing epilepsy and seizures is to choose the correct medication for the individual patient. Now, this may depend on the type of epilepsy, but also depends on the side effect profile, and this is why this topic is very important. Particular patients react differently to particular medications, and it's an important part of what we do on a daily basis. I'm also an associate professor in neurology at Wayne State University School of Medicine, and as part of my role, I do have research interests, including managing complicated and refractory seizures, epilepsy surgery and its role in managing seizures, as well as other related research interests in imaging and treatment of status epilepticus, which is one of the adverse occurrence in patients with epilepsy. I also take part in several multi-center clinical trials, which provide me with some clinical insights early on when new medications and new drugs are introduced to the world of epilepsy. So I hope that the combination of both my clinical and research experience can contribute to today's talk.
Excellent, excellent. Okay, so for a typical anti-seizure medication at a typical dose, what are the respective chances of having no side effects versus having noticeable but tolerable side effects versus having severe or intolerable side effects? I guess based on research findings or your just a rough estimate of based on your clinical judgment.
Yes, that's a very good question. We know more about the chances of developing severe side effects, so I'll start with that group. And the chances of developing severe side effects to the point where the patient or the physician discontinues the drug can range anywhere from 10% to 40%. So we have a wide range in the literature. I would say clinically speaking, it's closer to 15-20% of the time we introduce a medication that a patient cannot tolerate at all. So it is a significant number. I would say in terms of noticeable side effects, but are still tolerable, closer to anywhere from 25 to 50%. So essentially, there's a very small percentage of patients who will develop no side effects. So it's a very important part of the conversation early on when we're initiating medications to make the patient aware that, yes, you are likely to develop side effects, but this is what we can do. And having those expectations, I believe, allows the patient to kind of be aware and not stop the medication right away.
Right. Okay. So different anti-seizure medications have different mechanisms of action. Can you explain that term, mechanism of action, and how that influences possible side effects?
Yes. Mechanism of action is how a drug works on the molecular level. In other words, the specific site on the brain where the drug binds and subsequently results in therapy, in this case, seizure control, and prevent the seizures from occurring. for seizure drugs, this could be blocking sodium channels. That's a very common one, or blocking release of glutamate, which is an excitatory agent. In general, many of the seizure drugs can have multiple mechanisms of action, and certain mechanisms of actions have certain expected side effects, which is would more likely occur should you combine two drugs that have the same or similar mechanisms. So it becomes very important to know this information as we are choosing which drug to start and sometimes which drug to add.
Okay, makes sense. So side effects that tend to worsen as the dose of a medication increases are called dose-related side effects. Can you review some of the more common dose-related side effects of anti-seizure medications?
The most common dose-related side effects are fatigue and drowsiness. We also see dizziness, double vision or blurry vision, feeling off balance. These are often related to the dose.
Okay.
And are also common to many of many of the anti-seizure medications.
Okay, and I guess how would you classify side effects like nausea or gastrointestinal side effects? That would those not be considered dose-related? Or those more medication-related?
In some cases, they can, and that they may not be noted when you start the medication, and then when you escalate the dose, it may be related to you may see these side effects. In other cases, it's something that can occur, and the body sort of adjusts, and we don't see it later on when we escalate the dose. Okay,
great. So there's some degree of consensus regarding the approximate therapeutic range for each anti-seizure medication, which would be kind of the minimum level at which a medication is likely to be effective up to the maximum tolerable dosage. So if someone is at the maximum end of that range and is tolerating their side effects, but they're still having seizures, is it generally okay for the neurologist to push the dose higher as long as those side effects don't become intolerable, or are those guidelines kind of more strictly followed?
I would say that for the most part, yes, it is okay. The minimum and maximum levels are set and based on clinical trials done on hundreds of participants, so the individual experience may be different. If the patient is tolerating the medication and the patient and the physician believe it's worthwhile to try it at a higher than maximum suggested dose, then I think it is appropriate to do so with close monitoring. I do have to say, though, as long as the patient knows that the chances of having side effects is higher, just based on experience, and the chances that getting any additional benefit is lower. However, it's not prohibitive, and it's definitely treated on a case-by-case basis.
Okay, and presumably you've had some instances, at least in the many patients that you've treated, where that actually does work, I'm assuming.
Yeah.
Okay.
I have placed patients on the higher than recommended dose because they could tolerate it, and we've seen benefit.
Great. Okay, so what serious anti-seizure medication side effects, that typically require discontinuing the medication should people be aware of?
Yeah, so I would say any medication, not just anti-seizure medication, can result in an allergy, and not just in general. In the case of anti-seizure medications, developing a specific rash known as Stevens-Johnson syndrome is an example where you would definitely have to discontinue the medication. There are other side effects. such as the effect on white blood cells, effects on the liver. Those are other cases where the decision would be to discontinue the medication.
Okay. And it's in terms of effects on white blood cells and liver function, does that explain basically the use of testing for liver enzymes and that sort of thing? And does that, I guess, how do you determine whether you do that sort of testing for a particular medication?
Yeah, so there are certain medications where it's recommended to monitor things like liver enzymes, white blood cells, platelet count. So it does depend on the specific type of medication. Not all medications require monitoring of those things, and so it's variable as to which ones require close monitoring. And sometimes there certain symptoms arise, like abdominal pain or other symptoms that would require bruising, for example, that would require us to maybe do a little bit more frequent checks of the blood levels or the blood indices.
Okay. And does that tend to correlate, I mean, just roughly speaking, does that tend to correlate with older versus newer medications, or is it really just dependent on the individual medication?
In general, I would say the older medications require more or closer monitoring, but some of these side effects can occur in some of the newer ones as well. So if I had to say in general, the older medications require more monitoring, but the newer ones also, specific ones, have specific things that need to be monitored.
Okay. So in cases where a medication does need to be discontinued, how do you safely stop the medication so as to minimize the risk of additional seizures and potentially status epilepticus?
Yes, it does depend on the dose the patient is on. If the patient is on a very high dose and we have to stop it abruptly, then I prefer to admit the patient to the hospital and do it under close monitoring. If the dose is low and we have room to switch the patient over to a different medication without quickly stopping it, then I think doing it in the outpatient with close monitoring would be sufficient. So to provide some examples, something like Stevens-Johnson syndrome, which is a very, very rare occurrence, should that happen, definitely it needs admission to the hospital because you need to also address the Stevens-Johnson syndrome itself.
Right.
And then you would have to stop the medication the same day. Whereas, let's say there was mild lowering of the sodium, nothing too low, I would try to adjust the medication slowly or switch slowly over the course of some time. If the sodium level is very low because of a medication, and I think the medication is causing it, then that you would have to make the medication adjustments faster, and doing it in the hospital setting is safer for the patient. Okay,
great. Can you talk briefly about toxicity, particularly in older adults, and why that potentially happens, or why older adults are at risk for that, and what kind of some of the signs are of a potential toxicity?
Yeah, so the metabolism of medications in general is different as we age, and especially in specific medications that have a higher risk of interaction with other medications, and our older populations may be on multiple medications. So those things need to be considered. Reviewing someone who's older, reviewing the medications closely, and realizing that dose adjustments may need to happen at a slower rate is important.
Okay, and those symptoms generally tend to be those dose-related side effects that we discussed earlier, like basically symptoms that almost mimic intoxication.
Yes, definitely. And, in certain populations who are older, there may be also comorbidities that also cause, for example, balance issues. So if you already have a balance problem and then you're initiating a drug that has a side effect profile that includes balance problems, then you have to be even more careful with those dose adjustments.
Right. Okay. In many cases, side effects experienced when first trying a new anti-seizure medication go away or decrease over time. On average, how long after reaching a therapeutic dose should patients wait to see if side effects go away or decrease to a tolerable level?
I typically advise patients to give the drug about 1 to 2 weeks to get used to the higher dose. If the side effects are severe, then we may have to reduce the dose immediately or try it at halfway point.
Mm-hmm.
Sometimes keeping the patient on a lower dose for a longer time can help as well. So there are different strategies we can try to make sure that drugs can be tolerated at a higher dose.
Okay. Can new side effects ever appear after someone's been on an anti-seizure medication for a while?
Yes, that can happen, and that goes back to some of the side effects we mentioned already. You could be on the same medications for years, something like valproic acid or Depakote, and all of a sudden develop hepatotoxicity, which is an insult to the liver. Again, some of the side effects we already mentioned, like reduction in white cells in the blood, which can help fight infection. That can, it's called leukopenia, and that can happen all of a sudden, even though the patient has been tolerating the medication for a very long time. Now, those only occur in specific drugs, and that's why certain medications we monitor blood levels more closely than others.
Okay. In many cases, medication side effects can be similar to symptoms associated with the epilepsy itself. So cognitive difficulties, depression, headache, drowsiness are all examples of symptoms that can either be side effects or can be symptoms of epilepsy and associated conditions. So what are some ways to figure out if such a symptom is a medication side effect or not?
Yeah, that's sometimes can be very challenging,
right.
I'll be honest, to identify if the symptoms are related to the medications or not. In addition to what you mentioned, memory loss is another example, and that can be very challenging. You ultimately have to make a clinical decision and take a very detailed history to try to identify the source. However, additional testing sometimes can help, and this could include detailed neuropsychology evaluation, which includes memory testing. Sometimes that can reveal certain patterns that are specific to known side effects of certain medications. For example, word-finding difficulties that we see with Topiramate, that can show up in a detailed neuropsychology evaluation. Sometimes obtaining long-term EEG to look for subclinical seizures, or PET scan, which can help us identify that this is maybe related to the chronic state of epilepsy, can also help identify that this may not be related to the medications. However, at times we have to either increase the dose or decrease the dose, and that strategy in itself can help identify if it's related to the medications or not, based on either improvement or worsening of the symptoms. But definitely the testing that I mentioned can help.
Right. And presumably there can be cases too where someone is drowsy and assumes that is related to the medication, but could be a result of getting poor quality sleep, and in such a case, getting a sleep study would help, presumably.
Definitely, that's a very good point. So there are some things that comorbid conditions such as sleep disorders. So getting a good sleep history is very important in patients with epilepsy. That can help figure that out.
Okay, great. All right, so now we're going to do kind of a lightning round of sorts. So I'm going to say an anti-seizure medication or a group of related medications, and for each I want you to briefly discuss the one or two side effects that are most notably associated with that medication. Again, it's not saying that everyone with this who's on this medication will have that side effect, but I think many medications have kind of characteristic side effects that you kind of want to be on the lookout for, or that these are ones that are often associated with that. So just for each medication, talk about those kind of most notable side effects. And if you can, also mention any strategies for preventing or reducing the impact of these side effects. So are you ready?
Yep, let's
All right.
do it.
Let's do it. All right, so we'll start with levetiracetam, which is Keppra, and brivaracetam, which is Briviact, which are both closely related, but if you can talk about their characteristic side effects and kind of maybe any distinction between the two medications.
Yes. They both have similar mechanisms of action. They both bind to a specific protein in the brain. Their side effect profile, however, is a little bit different, most likely because they have additional mechanisms of action. So for levetiracetam, Keppra, it tends to be well tolerated, doesn't have a lot of the typical side effects we see with the dose-related side effects we talked about before. The biggest thing I'm concerned about when I start Keppra is to get a good history concerning depression or agitation after initiation of the drug. Although it's a small percentage, it can be pretty severe, and screening for that on patients with Keppra becomes very important. Whereas I don't see that as much with Briviact, and I see more of the typical dose-related side effects of drowsiness, sedation, fatigue, more with elevated doses.
Okay, great. And as far as the Keppra, the levetiracetam, I've heard of vitamin B6, I believe, as something that can potentially mediate that side effect of irritability or agitation. Can you talk just briefly about that and whether that's you found that to be effective, or there are other mechanisms or other preventive measures?
Yes, I think that has come to light over the last few years, is whether or not adding pyridoxine or vitamin B6 to when you start Keppra, would that help? And there has been some reports to do that. I personally have not initiated that, but I do know some of the pediatric neurologists that I work with have, with some variable outcomes. So definitely in the I think most of the studies have been more in the pediatric population, and something definitely to consider when initiating Keppra. I personally have not done it though. Okay.
All right, so now let's talk about carbamazepine or Tegretol, oxcarbazepine or Trileptal, and eslicarbazepine acetate, which is Aptium. And these are, again, similarly related medications, but sort of building upon each other over time. So can you talk briefly about those?
Yes. So as you mentioned, they're similar in mechanisms. They are sodium channel blockers. The most common side effects are drowsiness and dizziness, unsteadiness as well. However, the cognitive effect is less as you sort of move from Tegretol to Aptium, I would say. You don't have, Tegretol has a epoxide metabolite that can really have a significant effect on cognition. So the newer drugs tend to have less of the cognitive side effects. One thing that's common to all three is the risk of hyponatremia, and to mitigate both of those is to escalate dose slowly. That helps with side effects, and then periodically monitor the sodium level and other labs specific to those drugs.
Okay, great. Cannabidiol, or Epidiolex, which is one of the most recent medications.
Yes, and with Epidiolex, the biggest side effect, I would say, is drowsiness, but it also can cause diarrhea. This can be mitigated, especially the both side effects, I would say, by slowing down the dose escalation. So, every drug has a recommended way of titrating up to therapeutic range. Slowing that down a little bit and keeping the medication at a lower dose longer can help. For example, with diarrhea, allows the GI system to slowly adapt, and then once that stabilizes, you can kind of escalate the dose.
Okay. And with that being a relatively new medication, and I guess in general with new medications, how long does it kind of take for you to get comfortable with and get familiar with the typical side effects? Is it, I guess with Epidiolex, are you kind of getting there now, having been out for about a year or so?
Yes. So with Epidiolex, has been a little bit more challenging because it's not only new, but it's a specific population.
Right.
So you're not using it on all, a big group of patients. So getting to know Epidiolex will take a little bit more time, but it's also reserved for patients with very frequent seizures. So sometimes you have to weigh the potential side effect and your comfort with the patient presenting with very frequent seizures and sort of having an urgency to do something to help that patient.
Okay, great. All right, ethosuximide, or Xarontin, which is used primarily or exclusively for absence seizures. And you may not deal with that much as an adult provider, but
yes, I don't. I do have patients who have had that in the past. Rarely we have, adult onset absence, which is exceedingly rare. In general, Xarontin or ethosuximide is well tolerated. You can have some cognitive side effects, and again, you have to kind of slow down how fast you uptitrate that medication.
Okay. Another couple of medications that are closely related, Gabapentin, which is Neurontin, and pregabalin, which is Lyrica, both of which are used a lot in neuropathy, and probably less so than in epilepsy, but if you can talk briefly about those.
Yes. So they can be good drugs for patients who have both neuropathy and epilepsy. So sometimes we consider comorbidities when we start medications. And in that population, you have to, I think with both of these drugs, they can be sedating. However, if you lower the dose, patients can tolerate it. Some of the unique side effects to these drugs is they can cause abdominal discomfort, GI distress, which is not very common in other drugs. And I have seen it cause some swelling in the legs on a couple of occasions. I know it's been reported as well in the literature for that to occur. It's exceedingly rare. And again, I like using these drugs only if there's a pain component in addition to the epilepsy.
Okay, great. Lacosamide, or Vimpat.
This medication can cause the typical symptoms that we discussed already, dizziness, double vision. So closely monitoring the neuroexam when we first start the drug will be useful. I don't see those symptoms as as often, and I don't see them often when I initiate the drug. It's usually at higher doses. So working with Vimpat slowly can be beneficial.
Okay. Lamotrigine or Lamictal.
So Lamictal, one of the good things, I'll start with the good things about Lamictal, is it can have a positive effect on mood, and it doesn't have a lot of cognitive side effects like some of the other drugs. However, we do worry about a bad rash that we mentioned already, Stevens-Johnson syndrome, and this is why we have to titrate it very slowly. I use it quite often. I haven't come across the bad rash just because I work with it very slowly. That prevents us from, sort of if someone has a lot of seizures, you can't, throw a bunch of Lamictal at them. So it's limiting because of that, but it also has that positive effect of it being sort of cognitively clean.
Great. Phenobarbital, again, probably not used very often, but I know there are some people who were put on it a long time ago and it works. So,
definitely. I definitely don't start it on anyone new who just developed seizures, but I do have some patients who have been on it for a very long time, and it can be very difficult to take it off because it's either working or attempts to take it off in the past have resulted in withdrawal seizures, so there's definitely some hesitancy to stop it. It can be sedating. It can have cognitive side effects. It does affect the liver. It can cause skin rashes. So there is a reason why we don't start it. But if someone's on a stable dose, just following them closely, making sure you check levels. If, for example, new medications are introduced, because it can interact with other medications. Those are some strategies we use.
Okay. Phenytoin or Dilantin.
So again, older drug, but still commonly used, I would say, because it's one of the medications used to initiate patients on seizure medication in the hospital. So across the country, a lot of patients, after they have their first seizure, still do end up on Dilantin, although it's been less and less in recent years. Some of the unique features, I would say, for Dilantin, it does cause swelling of the gingiva, or not necessarily swelling, more like a hyperplasia. So it can affect long-term care of the teeth. It can have an effect on bone remodeling and can result in osteopenia or osteoporosis long-term, although there are a couple of medications like that, including phenobarbital. It has been associated with cerebellar atrophy. The cerebellum is part of the brain in the back of the head that controls balance, so that very long-term use of phenytoin has been associated with that.
And is peripheral neuropathy another potential long-term side effect?
Yes, actually, that is another one that can be seen with phenytoin. It also can be seen with carbamazepine as well. So some of those sodium channel, perhaps that's the mechanism. I don't know for sure, but yes, that can be a side effect.
Okay. Perampanel or Fycompa.
So this is one of relatively new drug. It's been out for a few years, and some of the side effects include drowsiness and balance problems. It can cause agitation and irritability at higher doses, typically, not at lower doses. So just monitoring closely and escalating the dose slowly is a strategy I use. One of the things to keep in mind with Fycompa, it's a once-a-day drug, which helps compliance. However, also it takes a very long time. It's a very long half-life. So you don't see the true side effect profile until it's a few weeks off. so you don't get to target level for about 3 weeks or so. So moving that drug slowly is important.
Oh, okay, interesting. Rufinamide or rufinamide, I'm not sure, which is Banzel.
Yes. Another drug that can cause balance problem. It can also cause vomiting or GI discomfort. Again, can have some of the dose-related side effects we've been talking about, and so slowing down the dose escalation is important here as well.
Okay, Topiramate or Topamax.
So Topiramate or Topamax has unique side effects.
Mm-hmm.
It can cause some cognitive slowing. It can be slightly sedative. People complain of having word-finding difficulties. This doesn't occur in everyone, but it can happen at higher doses. One of the things that we talk to patients about when we initiate Topiramate is it can cause some numbness and tingling at the fingertips or around the mouth. That usually goes away. So knowing, I think, which ones should go away and which ones persist is important. And some of the cognitive effects do improve after the patient's been on it for a few weeks. Sometimes they don't, and that's probably the number one reason I discontinue Topiramate is because in a subset of patients, they cannot tolerate the cognitive slowing or affect their ability to define words quite a bit. Some of the non-neurologic side effects of Topiramate is kidney stones. It can cause very rarely, I've never seen it, acute angle glaucoma. So, sort of a red, beady eye, but that side effect is exceedingly rare. Another side effect is weight loss, and that could be, in some patients, that could be a positive thing. If they are on a drug that is causing them to gain weight, sometimes Topiramate can be used to sort of counteract that. And I have used it for in patients who continue to have seizures and have gained weight, and you could sort of use that as a positive way. Now, in in patients who already have loss of appetite, you definitely don't want to start Topiramate. One of the things that Topiramate is used for is migraine. So someone who has epilepsy and migraine, we could also add this drug to help treat both.
Great. So valproic acid or divalproic sodium, which is Depakote. Yes.
Some of the specific side effects to Depakote is the tremor. It can cause a tremor. Actually, one of the things we didn't mention about Lamictal is it can also cause tremor, and a combination of Depakote and Lamictal can actually enhance the risk of getting that side effect. It's something that is that the patient can be very aware of and can give you immediate feedback. It's something you can identify on the neuro exam. So it's and some patients report that it's bothering them quite a bit to a point where we have to decrease the dose, and some patients can tolerate the tremor, and we're able to keep it at the dose at the therapeutic dose. Some of the non-neurologic side effects are hepatotoxicity, effect on platelets, so maybe tendency to bruise may be higher in a small group of patients. It can cause weight gain, and that can be that's probably one of the most common side effects or reports that I get from patients, that they have significant weight gain with Depakote.
Okay, and we'll talk a little bit later about some other issues with Depakote too, as far as pregnancy. So, zonisamide or Zonegran.
Yes, So zonisamide has a similar mechanism of action as topiramate. So you do see the loss of appetite. You do see some of the kidney stones we talked about. It can be sedating. I don't see the sort of word-finding difficulty, but more of drowsiness can be associated with zonisamide.
Okay. And then I didn't have this on the list that I provided to you because we just learned about it, but cenobamate was just approved, or Xcopri, I'm not sure how they're pronouncing it, but that was just approved by the FDA. Do you know anything initially about that?
I do. I have not used it yet,
yeah.
but because of just the new
not available
approval. But I do. I think one of the side effects is going to be also it's somewhat sedative. It has a effect on sedation or increases sedation, and can cause some drowsiness as well. I think that's going to be one of the more prevalent side effects.
Okay.
Until we use it, we don't know.
Right. All right. So I know we left a few medications off. Were there any that we skipped that you think we should mention?
I think this was a pretty comprehensive list, at least with the ones that we commonly use.
Right.
These are sort of some of the go-tos. Includes, some of the newer ones too. So nothing specifically that comes to mind that's not on this list.
Great.
That's the benefit nowadays of being a seizure doctor. You do have a lot of choices in medications, and even though every single one of them has a side effect, that side effect doesn't always occur in every single person. So we do have choices, and we can make changes depending on what develops in a specific patient.
Right. So a common concern about taking anti-seizure medications for a long time is the possibility of long-term or permanent side effects. We mentioned a couple of them when we were talking about the various medications. Can you talk about some of the possible long-term adverse effects of anti-seizure medications on the body and what can be done to minimize or reverse those effects?
Yes. One of the things we briefly mentioned is osteoporosis and effect on bone remodeling. And that's quite important because patients with epilepsy and seizures may not be as active because they're limited in what they can do, or because some of the side effect profile is drowsiness, so they may in general be a little bit less active than the general population. So the exercise becomes more important. Weight-bearing exercises become more important if can be safely done, obviously. In some patients, that's not an option. The other thing we can do to combat that is if someone has additional risk factors, so family history of osteoporosis, their body habitus, or puts them at more risk. So folks who are on the smaller side, who are petite, have a higher risk of osteoporosis. So for those patients, you could definitely order a bone scan. And if they're at a age where osteoporosis is common, that's another reason to do bone scans and look for that. And if you identify that, then that can be addressed with an endocrinologist, and you could also supplement with vitamin D and calcium, but some patients may need even more, so more traditional treatments of osteoporosis.
And do you generally recommend vitamin D and calcium supplementation for anyone taking anti-seizure medication for a long time, or only for certain medications, or I guess is there a agreed upon guideline there?
Yes, there isn't an agreed upon guideline. I think it's important to have that discussion and make sure that those risk factors are addressed with their primary care physician. I don't start vitamin D on everyone. If there are patients on, for example, what we discussed, phenytoin or phenobarbital, I definitely recommend them to have vitamin levels checked and then appropriately addressed if they're low. And in some cases, I do the bone scan myself just to look for it in someone who is older and their body habitus, they're small, petite, or patients who are wheelchair-bound who can't participate in bone remodeling exercises. So those can be even higher risk. Definitely if there's a history of fracture, because the seizure itself can put you at risk for fractures. So if there is a history of recurrent fractures, even any fracture, I think I'd like to make sure, although the seizure itself can cause it, that there isn't any underlying tendency for that to happen.
Okay. And any other long-term changes you wanted or side effects you wanted to discuss?
Yeah, so peripheral neuropathy is something that you mentioned as well. And that's, I think, definitely making sure physicians are aware of that and consider that, especially if there's nothing else that's causing the peripheral neuropathy. It's rare, but it's something that needs to be considered. If someone who doesn't have any risk factors or causes for the peripheral neuropathy, after digging, you still don't have an answer, think of the seizure drugs, and phenytoin is one of them. And some of the other things that we talked about is weight gain with Depakote, and that's something that needs, or and some of the other drugs, and that needs to be addressed, either sometimes through education and allowing the patient to know that this is a possibility. So do what you can in terms of watching what you eat and exercising, and sometimes we have to combat it by either reducing the dose or changing medications altogether.
Okay. And with the peripheral neuropathy, is that something that's potentially reversible if you stop the medication, or is that more likely to be a chronic issue even after stopping the medication?
Yeah, and it is rare to have peripheral neuropathy.
Yeah.
However, I believe that if you identify it early and you're able to stop the medication, it may not be a full recovery, but some recovery can occur.
Okay, great.
If you allow the nerves to regenerate because they're not getting that insult, it can potentially be reversible if you're able to identify it early.
Okay. So again, I know you're an adult epileptologist, but I know among parents in particular, there's often concerns that long-term use of anti-seizure medications or other medications even for that matter will have a negative impact on brain development. Is there any evidence of such an impact, or is that, I guess, what's the validity of that concern?
Sure. Yeah, definitely. I think there is. It's a concern, and unfortunately, it's not. I would say it's inadequately studied, but also it's challenging to study this because it's difficult to separate side effects or potential harm on brain development from the seizure medications versus the effect of the repetitive seizures. But we do know these are drugs that impact neurotransmitters, and in certain medications there has been data that if patients are on a specific set of medications, including phenobarbital, that could have an additional effect and a negative impact on brain development.
Okay. For women considering pregnancy, some medications carry a higher risk of congenital abnormalities in the fetus than others. Can you review what the research has shown and how you can counsel patients who are considering pregnancy?
Yeah, definitely. Counseling does have to start early. So even before a young woman starts planning on having pregnancy, the counseling should occur even before that, and that because ultimately once the woman finds out that she is pregnant, the brain development has already occurred. So always having this as part of the conversation for women of childbearing age is very important. And the changes can then be done before women become pregnant. So the biggest concern comes with valproic acid. It has the highest risk for causing both physical or anatomic abnormalities as well as cognitive abnormalities in a developing child. So for that reason, any woman with childbearing potential should not be on Depakote. There's very, very rare cases where we do keep Depakote on board, but that's only if there is, no other choices or attempts to take her off has resulted in very frequent seizures. Those are very specific situations. So I would say valproic acid is the biggest culprit. There has been phenobarbital is another one, also more concerning with cognitive and behavioral abnormalities. And actually Topiramate is another one that has been associated with having a higher risk of a baby with a cleft palate. So we do try to avoid these medications. Some of the medications that have lower risks include lamotrigine, so Lamictal, and Keppra, levetiracetam. So I do prefer those medications in women of childbearing potential if they can tolerate it and if it controls their seizures.
Great, thanks. So why is it so important for patients to tell their neurologist about suspected side effects and to never make changes in their medication regimen without first discussing it with their neurologist?
It's very important because any changes that are made need to be done in a monitored setting. We mentioned the risk of status epilepticus. We mentioned the risk of withdrawal seizures. So those can be very serious. So stopping the medication on your own can be very dangerous and even fatal. So I think it's very important to keep communicating with the neurologist about the side effects. And there are some things that can be done, such as bringing down, changing the medication altogether or bringing down the dose. Could be some strategies the neurologist can use.
Okay. Can you discuss the role of blood level monitoring, when and why that's needed, as opposed to simply using seizure control and side effects to determine necessary dosing changes?
Yes. Ultimately, seizure control and side effects are better than blood level monitoring. So I do believe treating the patient clinically is better than following numbers. However, having said that, I do believe identifying what is a good level for a patient, so when the patient is stable, getting a blood level may be appropriate because now we know what is a good, safe level for you. So should the levels drop or increase for any reasons, should another medication be introduced that interacts with this particular seizure medication and change the level, we would know how to react. So that's the importance of blood level monitoring in patients who are stable. Blood level monitoring can also be important when side effects arise. And again, you can determine, okay, for this particular patient, a blood level of Keppra at 40 is too high. So I am going to try to keep the patient at a lower dose. It's to get a baseline. It's to monitor for side effects. And sometimes it is to ensure, should we add additional doses, it doesn't result in interactions.
Okay, great. All right, so before we open it up for questions, do you have any closing thoughts for our listeners? I think we were pretty thorough. I think this is a great topic to discuss here and to discuss with your neurologist, most important. And just realizing that everybody is different, and although these side effects are common, they may not necessarily occur in a particular person. And if they do occur, there are some strategies that neurologists can do to decrease the incidence of them. Okay, and actually, before we do open it up for questions, I just thought of another one myself.
Yeah.
Can you give a few examples of situations where adding another medication to combat a side effect may be appropriate?
So we actually discussed the weight gain, weight loss side effects. So adding Topiramate to combat weight gain, maybe, or zonisamide, in fact. Zonisamide is another drug you can add to combat weight gain. I would not do it just to combat the side effect. I would do it if there's also difficulty to control in seizures and to combat the side effect. Another one is the tremor. Topiramate can also help with tremor. So those are two things. And then the second medication can be added at a lower dose so that it itself doesn't cause side effects.
Okay. Yeah, and I guess I was getting at like adding a non-anti-seizure medication to combat a side effect from an anti-seizure medication. And I can't think of any examples off the top of my head.
I can't think of anything right now.
Okay.
I don't. I can't think of anything because most of the side effects are drowsiness and off balance,
sure.
And those are things that we can't necessarily address medically.
Yeah, like so something like if someone was having really good seizure control with a medication like, let's say, Banzel, for example, since you mentioned that can have GI effects, but they had severe nausea, is that a case where you could use some sort of antiemetic or something like that to...
I mean, that's a great example, actually. I didn't think of it, but but that is an option. That is definitely an option. The same with the diarrhea with Epidiolex. Sometimes diet control and using things to combat the diarrhea may help.
Okay, great. Yeah. All right, so let's go ahead and open it up for questions. Okay, so who would like to get us started with a question?
Hi, this is Marissa Morgan. Hi, Dr. Basha.
Hi, Marissa. How are you?
I'm doing good. I'm one of your patients.
Good to talk to you.
I wanted to make a comment. In the past 20 years, I have taken quite a bit, 8 of those medications that you and Russ had talked about.
Okay.
Dilantin is the one that seems to be working best for me. And as you were talking about the side effects, one other side effect, you did talk about weight gain.
Yeah.
And I had learned about from the Dilantin of when to take the medication, because I had to stop taking it so late because it was making me hungry. and I found myself eating, later, and I started, taking it a few hours earlier, and then also helping my weight gain, exercising and going out walking and doing a little bit more things. And then also I am on a medication for the prevention of osteoporosis. Okay. And that, too, seems to be helping out quite a bit. So I can safely say, and with good intentions, that in the past 20 years, I feel better now than I did 20 years ago.
Yeah, you bring up a very, very good point in that there are some things you could do that can combat some of the side effects, like exercise if there is weight gain. The timing of medication is also important. In your case, you mentioned changing the time of when you take the medication. That I also see with drowsiness or kind of feeling off balance, sometimes taking it in a certain time in the evening, especially for medications you can take once a day, that becomes important. So those are very good points.
Yes.
Yeah. Right. Thanks,
that was it.
Yeah.
Thank you.
And I'm sorry I missed. I had an appointment last Wednesday, but I had to babysit. But I'll be seeing you in the next couple of months.
Excellent. I'm glad. Very good. I'll see you soon then.
Okay.
All right. Who else has a question for us? Got a lot of time left, so don't be shy.
Yes.
Okay. Does anyone have any comments? We'll expand the options here. So anyone have any comments or things they'd like to share, experiences of a particular side effect that you've noted, or ways that you've effectively dealt with a side effect? Anyone have anything to share?
While they're thinking, I do want to add one comment.
Sure.
That just as our last caller stated, there's no real bad and good drug. I think as long as a drug is used, it's benefiting the patient, and we can manage the side effects. There isn't a drug that should be labeled as a bad drug. And that's important, I think, to keep in mind.
Right.
Yeah.
Yes, Doctor, this is Kathy. How you doing?
Hi, how are you?
Okay, how are you?
Good.
For my seizures, I've been taking Keppra, Keppra XR, Vimpat, and they just told me this about a year or so ago about my clozapam. I was given clozapam from my regular doctor just to help me sleep.
Okay.
What do you say about Vimpat? I haven't heard you say much about Vimpat.
I think it's a very good. I know I just said there's no good and bad. So it's very efficacious. I've had very good success with Vimpat in stopping seizures, with not a huge amount of side effects. I think maybe that's why we didn't talk about it as much. It does give you the typical side effects of dizziness and drowsiness, but I found that a lot of patients can tolerate it very well, especially if you have the option of maybe, not pushing it completely to 200 twice a day, or maybe staying longer at 150 twice a day before having to escalate if you do need to escalate.
Well,
I don't know what your experience may be different, though. How did you like it?
It's fine with me. I take it 4 times a day, but I spread it out really.
Sure.
Unlike neurologists or epileptologists, like with my Keppra, they wanted to give me 1,000 milligram tablet, and I told them I couldn't tolerate it. It's just that I told them, why can't you lower it? And they said, well, the lower it would be the name brand. And, of course, doctors and insurance companies want you to take this generic junk, but Keppra, they lowered it down, and I take Keppra and Keppra XR. Okay. And I've spread it out all the way around during the day, and my one change that I done was Keppra XR, I take it 1-2 times a day, and Keppra 1-3 times a day.
Okay.
And I feel it works better with the XR and the regular Keppra.
Yeah. I think that's that's a strategy we did not talk about, which is spreading out medication. Obviously, our goal when we're prescribing a medication is we like to keep it, twice a day or once a day for those drugs that work that way. But sometimes that doesn't work very well for the patient. And if like you're able to spread it out, and that's the only way you can tolerate it without missing any doses, I think that's a very good strategy to minimize side effects.
And to build upon that, do you find in general that side effects tend to be a little bit better or fewer side effects with extended release formulations than the delayed release formulations, or is that an overgeneralization?
I think there is a little bit of better side effect profile, because you're not, just based on the pharmacokinetics, you're not peaking as much. So in a medication that needs to be taken multiple times a day, the medication will peak immediately after, just so that it can sustain you to the next dose, for example, in a 3 times a day medication. But so the extended release doesn't have a bigger peak, and it doesn't have a bigger valley. So you're maintaining a good dose throughout. However, that doesn't always work for certain patients, and even extended release once a day drugs, sometimes certain patients, as our caller just referred to, they need to split that up as well. So in those cases, just because it's extended release doesn't mean we have to do it once a day. The less, I do like to prescribe things that the patient can take all at once if possible, twice a day or once a day, but that's only because compliance is better. It's
right.
easier to remember those. But if the patient feels better by spreading it out and will not miss their medications by spreading it out, I think it's definitely something the neurologist should consider.
Okay. To build upon another couple of things that Kathy brought up, also, she mentioned clonazepam, and so we haven't talked about benzodiazepines and kind of as-needed medications and their potential side effects. Can you just briefly talk about the things that people have to be careful about or cautious about when using benzodiazepines?
Yes, definitely. Actually, when Kathy mentioned that, I did realize that's a group we did not cover. They can be sedating, and I think that's one of the things to watch out for. They can also develop tolerance, so they may initially work for seizures, but then they stop working, or then you require a higher dose. However, if used sort of as a rescue medication, meaning only when patients have big seizures like we do with Diastat, or now we have the nasal midazolam out as well, if those are used as needed, they can be very efficacious in a very specific population. But it sounds like there's other reasons that Kathy's also taking this medication.
Mm-hmm.
So that should be considered. And so certainly, for example, if someone is already on a benzodiazepine, I would be careful to add a second one too. So, one of the more common ones we recently been using is Onfi, or clobazam, which doesn't have that tolerance. Meaning that you don't necessarily, it doesn't lose its efficacy as much as other older benzodiazepine. However, it wouldn't be the first medication to think of to add to her regimen, because she's already on benzodiazepine. So combining benzodiazepines is not something that we like to do.
Yeah, and I realized I'd forgotten Onfi, which is somewhat unique in that it's one of the few benzodiazepines that's used like as a daily anti-seizure medication.
Yes, as an anti-seizure medication.
Just in general, what are the biggest side effects with that, or the most prominent?
So with clobazam or Onfi, it can be very sedating. So you know, even though the smallest tablet we have is 10 milligrams, I almost never start 10 milligrams twice a day. I like to split them with the patients and start at a lower dose, just so that they can get used to them. And drooling can be something as well that is common with Onfi.
Okay.
So those are some things. Combining actually Epidiolex and Onfi can be something that people need to be aware of, that the Onfi level can increase.
Right.
In many cases, I've had to decrease the Onfi level or dose just so that I'm able to up-titrate the Epidiolex.
Right. Okay, and one last thing that Kathy mentioned is generics. Can you just briefly talk about the potential for side effects with generics because of that, the increased range in bioequivalence?
Definitely. So for the most part, replacing a brand with a generic, if someone is stable on and does not have a lot of seizures, can be okay, and patients will tolerate that well. However, the danger becomes when you switch from one type of generic to another, because then your bioequivalent can go from a upper limit of high dose to upper limit of a lower dose, and that can result, or the other way around. So that can result in either breakthrough seizures or toxicity. Again, in general, patients do well, but in certain patients where they're not controlled, or they're barely controlled, we finally got them to be controlled. Definitely, it's not the time to switch to generics, and keeping them on brand may be best. Or when they do switch to generic, what we discussed with the levels, that would be another reason to monitor their levels.
Right. Okay. Other questions?
Hi.
Yep.
Yes. Hello.
Go ahead.
Can you hear me?
Yes.
Yeah.
My name is Marilyn. I have a question about Epidiolex.
Sure.
Our daughter was on that and had some fairly significant side effects, including the diarrhea.
Yeah.
I'm just curious if you can comment on a non-FDA approved CBD oil like Charlotte's Web, which I've read that some people, because of the diarrhea, have switched to that, and it's been successful for them.
Okay.
It's really hard to understand what's the difference between an Epidiolex and a Charlotte's Web type of CBD oil.
Yes. So the biggest difference, there's a couple of differences, and one is your CBD oil, we don't know what the doses are, what's the actual CBD dose in there, and it can be highly variable from one to another. So that is one drawback. Most likely, the amount of CBD in a CBD oil that you purchase in the non-FDA market is not at the same dose as the Epidiolex, and the Epidiolex is a significantly higher amount of CBD, and that's sometimes, even though the recommended dosage of Epidiolex may be, 5 milliliters twice a day or whatever it is, it may be worthwhile to bring it down to 4 or 3 or even 1 to start out with and see. Because ultimately, you know exactly what's in that bottle, whereas if it's non-FDA, in most cases it's going to be okay, but we don't really know.
Right, and there are even some cases with some formulations of CBD that you can buy online or at provisioning centers where the dose is so small that it almost borders on like homeopathy, where there's almost no CBD in there,
right.
or the dose is so small as to be highly unlikely to have any effect. So that's probably the biggest difference in terms of the side effect is just the major discrepancy in the dose.
Yeah. Yeah. So it may you may have less side effects, but you probably are not getting much of the CBD itself, basically.
Okay, thank you.
You're welcome.
Other questions?
Well, I have one more. So did you mention Felbitol?
We did not talk about Felbitol, actually, Felbamate. So it's one of the older drugs. However, it can be very efficacious. The reason it's not as common, I probably just have 2 or 3 people in my practice on Felbamate, mostly because of the risk of aplastic anemia, which is a complete shutdown of the bone marrow. However, patients who've been on it for a very long time, as long as you frequently check their blood counts and they're tolerating it, then for the most part they're doing well. But because of that risk of shutting down of the bone marrow when you initiate it, it's one of those drugs that not a lot of seizure doctors are starting.
I guess to follow up with that, do you get enough? Is there a way to initiate it so that you get enough of an early warning that you can stop it before anything permanent or irreversible happens, or is the onset so quick and so difficult to identify that it's just the risk is just too much for some people?
Yeah, I would say it's the latter, is that it can happen without any significant physical manifestation. So by the time you've identified it, it's too late, and that risk, even though it's small, is dangerous enough that many of us don't start it. And we continue it on patients who've already sort of been on it for years and it's working, but we don't typically start Felbamate.
Okay, great.
So based on that, somebody's been on it, you said, our daughter's been on it for like 20 years.
Yeah,
and she went on it before they discovered that side effect.
Yeah.
And so it's a really effective for her. So do we know, could she suddenly get this aplastic anemia, or is it really just in the beginning?
The cases, the cases are very small, and the cases that have been reported have not been in patients who've been on it for 15 or 20 years or whatnot. It was early on in their disease process, but we're talking about we're talking about very few, less than 1%. We're talking about a risk of 2. I don't remember the latest quote, but maybe like 1 or 2 per million per year type of a risk of occurrence. So because of that, in the patients that are on Felbamate, and it is often cited as the only drug that worked, I don't stop it. I think the risk of aplastic anemia in those patients is so low that I just am careful about making sure they get blood testing and screening, and making sure that it's not affecting them.
Thank you. And many years ago, our daughter went on the ketogenic diet, and I will just say that was an amazing difference in her after that. Unbelievable.
Yes. Yes, that's a session on its own, I think.
Right.
Yes, but I completely agree that there's definitely a role for dietary adjustments in patients who fail a lot of drugs.
Okay, we've got about 5 minutes left. Other questions or comments?
Again, Russ, this probably doesn't have nothing to do with the medication, but what's that diet thing again?
The ketogenic
diet?
was
just talking about?
Yeah, ketogenic diet, and then there's 2 variations on that diet, or 2 primary variations on it: the modified Atkins diet and the low glycemic index treatment, both of which are a little more flexible and a little easier to stick with, but they're all high-fat, low-carbohydrate diets that can be effective, typically in addition to medication, but there are some people who have it become seizure-free and are able to go off medications. That's pretty uncommon, but many people are able to have success, and it's being used more often in adults. Mostly those 2 variations on the diet, because the full ketogenic diet is very difficult to stick with, particularly if you've enjoyed food before. It's
right.
It's not something that most adults can switch to. So, but it's definitely something to discuss with your doctor if you're interested in pursuing that. And we've done a couple of different Learn and Share conference calls on that topic that you are welcome to listen to. Okay, maybe one more question. Anyone want to?
I was just going to say, what do you say about people who's getting older and have seizures?
In terms of side effects?
Stick with the, yes.
Okay.
Can you repeat that one more time? I'm sorry.
What do you feel, or how do you feel about people that are getting older and still have seizures and taking medications? Like myself, I'm going to be 50 next year, and I've had seizures since I was 2 years old.
Yes. So there are certain things to be considered when we are older and we're still having seizures. One of the things is now you may start being on medications that are unrelated to your seizures. So things like maybe not now, but in the future, things related to blood pressure or cholesterol, just things that show up as we get older. So it is important to make sure that the seizure medications are addressed in that fashion. The other thing is to make sure that you have a conversation with your neurologist about additional options. Are there additional options that they need to explore for you if they haven't already? And they may have, and you don't qualify for any additional options, like the dietary things that we mentioned, like epilepsy surgery or vagal nerve stimulator. So those are the things probably I would consider, is making sure that age-related issues are addressed, but also do you have a full evaluation, or are there additional options you need to explore?
Yeah, and I think you raised another important point, which is communication, between the primary care physician, the neurologist, and the patient, just to make sure that everyone is on the same page in terms of other health conditions and other medications that are being taken. And that includes medications that are over-the-counter or supplements or herbal supplements or complementary therapies that you may not even consider as a medication. Many of them can have interactions with anti-seizure medications, and that could cause the dosage to go up, which could cause side effects.
Yes, very good, definitely.
Yeah, because I take vitamin E, 1,000 milligrams, vitamin B12, vitamin D3, and folic acid.
Yes. Yes.
Yeah,
Yes.
and
Just making sure that your neurologist knows about that, and I think is the most important thing.
right.
Right.
Okay, so I think we'll go ahead and wrap it up. So thank you everyone for participating today. I found that very helpful, and thank you so much, Dr. Basha, for all of your insights on medications, and did great in the lightning round. I know that was a challenge. So, just want to remind people, if they have further questions, to please contact us at 1-800-377-6226 or visit our website at epilepsymichigan.org. This is the last Learn and Share conference call of the year, and keep your eyes open for the calendar for 2020. It should be coming out soon, or the schedule of calls, and hopefully we'll have a great set of new calls and speakers and topics. So again, thanks everyone, and thank you so much, Dr. Basha, for participating.
Thank you. My pleasure. Take care.